good afternoon. In order to encourage quality patient care, the ASA released guidelines and standards of monitoring, which included this statement. Okay. However, temperature continues to be the least monitored parameter intraoperatively, with the exception of subspecialty cases, or until absolutely necessary. So temperature derangements can be detrimental to our patients, and monitoring of temperature pre, intra, and post-operatively can assure patient comfort as well as avoid possible complications. So can I please have a raise of hands in the audience? How many here actually monitor patient temperatures intraoperatively? Routinely. Okay. Routinely. Okay. Okay. Not a lot. Not routinely, right? Okay. So this is the outline of our lecture today, and I just have to disclose that I have nothing to disclose for this lecture. So naglalag ang laptop nyo. Okay, so we'll start with the physiology of temperature, of thermoregulation. Okay, sorry. Okay. So the body temperature is not homogeneous and is divided into two compartments. The core, which holds 2/3 of the body's temperature, is maintained within a narrow range of 36.5 to 37.4 degrees Celsius. And it is made up of the major thoracic, abdominal, organs, and the brain. The peripheral compartment is comprised of the limbs, skin, and subcutaneous tissue and contains about 1/3 of the patient's body heat content. The temperature of the periphery varies widely from 0 to 40 degrees, but it is usually kept within 30 to 32 degrees. So body temperature is a vital sign. It is tightly regulated, more so than blood pressure or heart rate. Every part of the autonomic nervous system participates to some extent to keep the body temperature stable. So there are three phases to thermal sensing. It begins with the afferent thermal sensing, which involves thermal receptors predominantly in the skin. These signals are made in the skin when a temperature derangement is sensed, and these will be sent to the central regulating system, which is generally the hypothalamus. These signals will then trigger a regulatory response through the efferents, which in an awake patient is usually through behavioral modification, and followed by non-voluntary thermogenesis in the unawake patient. So this figure shows the temperature thresholds for each response. So the temperature between sweating and vasoconstriction, signified by the blinking oval, is defined as the interthreshold range. So this is the range where no autonomic response is initiated due to temperature changes in the body. Okay. Beyond this range, there will be already autonomic responses to the fluctuations in temperature. So as you can see, sweating will happen first before active vasodilation is actually initiated. However, compared to shivering, the patient will first become vasoconstricted, and 1 degree later will start shivering. So when you see your patients already shivering, they are already relatively hypothermic. So heat production is a byproduct of normal metabolic activity. Behavioral regulation is the most powerful response of humans to temperature derangements. But this response requires conscious perception of body temperature. So the unconscious methods of heat production include vasomotion, shivering, and non-shivering thermogenesis. Similarly, heat loss is also an active process and is primarily through behavioral regulation. Sweating is the most important non-voluntary response to excess heat, and vasomotion the second. Heat gain and loss can also be through environmental exchanges of heat. As you note here, radiation has the most effect on both heat loss and heat gain. So now let's discuss the thermoregulatory changes that our surgical patients can experience. So hypothermia is defined as any temperature below normal core temperature, and it signifies the body's inability to produce heat to compensate for loss. So it is classified as the following based on core body temperatures. So what causes hypothermia in our patient? So these are the usual causes of hypothermia that our patients, the reasons why our patients will become hypothermic in the OR. And these are the consequences. So a special mention should be made about shivering. So shivering occurs in about 40% of all patients who are in the operating room. And it's apparently benign. Sometimes we don't do anything about it, especially if it's a first-year resident. They just, she's just shivering, just put a blanket over them. No? But it is very important to note that shivering can actually increase oxygen consumption by 100%. It can also increase intracranial pressure. It can also increase intraocular pressure. It can increase pain by stretch. And it can definitely increase cardiac morbidity. On the other hand, hyperthermia is defined as any temperature above core body temperature, and it's classified as the following. So to differentiate fever from hyperthermia, fever is an increase in the hypothalamic set point, while hyperthermia is when heat generated by the body exceeds the body's ability to dissipate this heat. So fever is usually infectious in cause, but not just infectious in cause, while hyperthermia is usually a central cause. So this is a small slide for the causes of hyperthermia. Okay, and this is the more extensive slide. Okay, so the blinking box, you can see, these are the most important reasons for hyperthermia that we as anesthesiologists will face: malignant hyperthermia and drug-related hyperthermia. So these are the consequences of hyperthermia. So as anesthesiologists, what we do affects our patient's ability to thermoregulate in a very predictable manner. So anesthesia decreases metabolic rate and abolishes the behavioral responses that maintain body temperature. Our patients will in turn rely solely on autonomic defenses and external thermal management. But it is important to note that the autonomic defenses are also impaired during anesthesia. So as you can see, the warm response thresholds are slightly elevated, the cold response thresholds are markedly reduced, and the interthreshold range will be increased. As you can see in this figure, this is the normal. As you can see, the interthreshold range is increased. Okay. This second figure will show the redistribution of heat from the core to the periphery, and the decrease in core temperature because of the dissipation of heat to the periphery. So in general, inhalational anesthetics, sedatives, hypnotics, and opioids impair thermoregulatory control. The sweating and vasodilation thresholds are slightly increased, while the vasoconstriction and shivering thresholds are decreased, as you can see in this graph. Okay, so this table will just summarize general usual anesthetics that we use and the effects. So this figure shows the changes in core temperature after induction of anesthesia in infants, children, and adults. Okay, so hypothermic changes usually occur in 3 phases during general anesthesia. So the first phase happens after the first hour of induction and usually corresponds to the fastest loss of heat of about 1 to 1.5 degrees Celsius per hour, and this is due to redistribution. Okay. The second phase is a linear reduction of, It's a linear reduction in core temperature of about 1 to 2 degrees Celsius over 2 to 2.5 hours. No, and this corresponds to redistribution of heat and as well as evaporation and other environmental transfer of heat. Also respiratory heat loss, which accounts for about 10%. The third phase occurs 3 to 5 hours into anesthesia, and this usually occurs when vasoconstriction is maximal, happens about 33 to 35 degrees Celsius. And this is the point where there is no more heat loss because vasoconstriction is maximal, so there is no dissipation of heat. So as you can see, it is usually a plateau already. So at 3 to 5 hours into anesthesia, the heat loss will be at the most, and it will be stable until the end of your surgery. So let's discuss for neuraxial and combined GA. So although local anesthesia used in neuraxial anesthesia do not reach the brain, patients